Welcome to Inspired to Heal, a podcast that celebrates the careers of dedicated innovators, educators, clinicians, and leaders within government-run health institutions. I look forward to sharing their stories, honoring their contributions, and inspiring others. Season 1 focuses on former staff at Cook County Hospital. They all played key roles in building and implementing state-of-the-art programs in Chicago's safety net health system. I'm Bill Trick, your host for Inspired to Heal. Today, I'm honored to host Dr. Brian Lucas, Associate Professor of Medicine of the Dartmouth Health Institute, physician at the White River Junction VA Medical Center, and national expert on the use of bedside ultrasound by hospital medicine physicians. When I was hired at Cook County, Brian was one of the first physicians I met. We attended a presentation about unconventional ways to present research findings. Over the years, it became apparent that whether it's work or hobbies, Brian has a healthy contempt for orthodoxy. His curiosity, tenacity, and resistance to accepting the status quo, with the support of forward-thinking leadership, motivated him to develop the bedside ultrasound and procedure services and a short-stay unit to decompress a health system that had a surplus of patients and a limited capacity of inpatient beds. But first, I will introduce you to medical terms used in this interview. POCUS is the acronym used for point-of-care ultrasound, which is an ultrasound test performed and interpreted at the patient's bedside. The use of POCUS is helpful for therapeutic interventions or medical procedures such as inserting large catheters into blood vessels to rapidly administer medications or blood products. The term OBS is a shortened version of observation unit for patients who can't be safely discharged from the emergency department, but who do not warrant admissions to an inpatient unit. The final term you will hear, ED, is an acronym for emergency department. Brian, welcome to Inspired to Heal, and great to have you on the show.
Thanks, Bill. It's really an honor to be asked to do this.
You went to school at Stanford, Columbia, and trained at the University of Chicago. After that impressive academic background, your first job was at Cook County Hospital. What motivated you to come to Cook County?
Yeah, my poor parents, I think after contributing to a lot of that education, they probably figured, what are you doing? So I finished my residency at the University of Chicago, and then I was a chief medical resident at Cook County. After that year finished, they didn't have a position for me. So I was working at an hourly wage, and I didn't have healthcare benefits. And I think my parents were probably wondering, what are you doing?
Did you actually hear that from your parents, or you just wondered?
I don't think they had a clue really what I was doing. But now that I'm a parent myself and thinking about my own kids' future and knowing how expensive it is to get the education that I got, thinking, wow, if they go off and work for $52.50 an hour, I'm not sure it's going to be worth it. At the time, I was a little disillusioned with what I had already seen in medicine and healthcare. No offense to the University of Chicago at the time, but it wasn't really what I anticipated it would be. Moving from Manhattan to the south side of Chicago, that was an intentional move. It wasn't really fulfilling my vision of what I thought it would be, which was doing more for the people in the community around the University of Chicago. Just as an example, I remember getting there and learning that they had reduced the size of the trauma unit and intentionally not accepted patients with HIV. The reason for that was because it's hard to run the business of a hospital with those two patient populations because it's not a way to generate money. So I finished my training there. I was thinking about things abroad and heard about this opportunity to become a chief resident at the University of Chicago, where you got a decent salary.
At Cook County.
I'm sorry, at Cook County. Mm-hmm. You got a decent salary, and it was all about teaching. Most chief resident jobs are a lot about administration. When I got there, I was completely in love with what was going on there on so many levels. So the patients were fascinating, incredibly diverse, early manifestations of disease, just because if you're 65 or older in the United States, you can get your care pretty much anywhere as long as you're a citizen. A lot of the people that go to Cook County are younger, and so you're seeing them for their initial manifestations of disease. Patients were fascinating. The cases were amazing. The group of doctors that we were working with was incredibly diverse from all over the world, very interesting. And then the quality of the people that were there. A lot of those people I imagine you're going to be interviewing for this podcast. Art Evans, Brendan Riley, Christopher Smith are three people in particular who, when I first got there, I thought this is actually the type of educator and physician that I wanted to be. Fell in love with it and didn't really expect to fall in love with it. But then, as I said, even though my chief year was up and they didn't have a position for me, I just stayed there working $52.50 an hour, hoping something would open up. That's when the whole hospital medicine movement started. I was kind of in the right place at the right time and was asked by Dr. Riley to run the new division of hospital medicine.
So you were the founder or the initial division chair for hospital medicine.
Yeah, and it wasn't quite that smooth, actually. It was a small group initially of myself and a couple of other recent chief medical residents, and we were within the division of general internal medicine before we became our own division of hospital medicine.
That was a common theme. A lot of the innovation that I think I witnessed came from the division of general medicine.
Yeah, I think that's true. Avery Hart was the division chief, and he was very supportive of what we were doing, a great educator. Eventually what happened is the whole movement of hospital medicine was growing pretty rapidly across the country. There was increasingly an expectation that outpatient general internists were not going to spend a chunk of their time on the wards. Our numbers just continued to grow. By the time I left county, after about a dozen years, I had hired close to 30 docs.
Yeah. And I mentioned there is a short stay unit that you started where you took care of patients with congestive heart failure or chest pain. And the idea was that you could do a rapid assessment and determine whether they needed a full admission or could be discharged safely. You also spearheaded the POCUS, or Point of Care Ultrasound Service, and became the lead of the procedure service. So of those programs, which one do you feel was the biggest success or the one that you have the most pride in?
Well, you're giving me way too much credit. I guess in some way I did have a hand in all of those things. But, for example, the short stay unit was something that was devised as a collaboration between Department of Medicine and Department of Emergency Medicine. And when we moved to the new hospital, they already had an area that was staked out for an observation unit. Dr. Riley and Art and Dr. Shader in the ED and Trevor Lewis and I came up with this conception of the short stay unit, which was basically an OBS unit but a little bit longer stay. The need for it arose because when we moved from the old hospital, which was like 6 or 7 stories high and had tons of beds, to the new hospital, they basically increased the size of the front door because they increased the size of the beds in the emergency room, but they reduced the size of the upstairs dramatically. So we needed a way to move patients through, get the care they needed, but not bring them upstairs to the regular wards. The short stay unit was a lot of fun. One of the best things about it was that you and I worked on the short stay unit together.
Yes.
One of the best things about the short stay unit was that you were actually working side by side with another senior physician. And that's so rare in academic medicine these days, I think.
For the record, you were the senior physician of the two of us.
I remember that experience because there's always so much you can learn by watching another physician and educator do what they do. Just to give you a concrete example, I did a lot of the short stay with Dr. Riley. Dr. Riley is like the storied diagnostician.
Yes.
We'd hear about the list of patients and we'd divvy up who was taking what patients in the morning. I'd tell him which patients were his, and he would just go straight into the patient's room. Just wanted their name. Wouldn't look at the chart, wouldn't look at the electronic medical record. And you could hear what he was asking because it was just a bunch of curtains that were separating these different beds. He would always just start with, what brought you to the hospital? That was very life-changing for me in the way that I would approach patients. It's very patient-centered. It's also really important for not clouding your preconceptions with what the previous, in this case, emergency room physician thought was going on. One of the things that was so great about the short stay unit was just picking up little different ways of practicing and communicating with the trainees. I guess that's the program that had the most impact on me, and in some ways I'm the most proud of. Over the years, I've worked with a lot of proceduralists and POCUS gurus who have exceptional skills at point-of-care ultrasound and at doing procedures. Ricardo Franco Sadud wound up becoming really world-class, Carolina Candotti, in ultrasound skills. I never really became the superstars at those things that they were. My role was to help administratively, and then we were trying to bolster the academic credibility of our group, given the freedoms that I had by the powers that be, was able to study those things effectively. The meta project that I'm really most proud of at County was this idea that with a little bit of experimental methodological rigor, you can roll out a new project or program, study it rigorously, and then capture something that is scholarly and even goes beyond the walls of your own institution.
You bring up what I think is a very important point, and one of the things that I would like to explore with you is the value of having research within an institution. That Cook County is considered to be an institution for clinical care. That's the mission of the institution. Sometimes research can be lost in that. What is the value of research at a public government-run institution?
Yeah, I think it's critical. You know, you walked in and out of that big administrative building. There was some kind of governmental emblem above the staircase. I think it was the representation of a three-legged stool. It had science, and then it might have even said the word art. The third thing had something to do with training or education. I now work at the VA, and the VA has a similar mentality of a three-legged stool. It's about education, it's about research, and it's about clinical care. And I like that idea because I think those things depend heavily on each other, and on a couple of levels. One is, if you're at a place like Cook County or a place that's run through a mission, you need really good people working there. And really good people have a bunch of diverse goals and ideas and aspirations. I, for example, was really interested in the education training side of medicine, and then later became very interested in the research side of medicine. I found a home at Cook County, and I know there are other people, you for example, very interested in the research side of things. Art Evans, very interested in all those things, but definitely in the research side of things. Chris Smith, very interested in the teaching side of things. The more you can round out the experience, I don't mean this in any disparaging way, but the more you can round out the experience so that it's more than quote-unquote just clinical care, I think the more you're going to be able to attract really good people. So research can do that for some people, myself included. It can get them interested in participating in the overall mission of the place.
Certainly, when you started and when I started, there were excellent clinicians, and that was their focus, and that by allowing people who were interested in research to join the faculty, it did create that diversity.
Yeah. Aside from bringing in people to work at a mission-oriented place, it does serve a more direct purpose in terms of clinical care just by potentially doing the research to figure out what is the best way to deliver care. The trick is how to do that in a way so that it's just not about the future patients, but it's actually about the patients that you're currently caring for. As a concrete example, so when we did the hand-carried ultrasound echocardiogram study, right, that was a randomized controlled trial. We were training up hospitalists to be proficient at hand-carried ultrasound with the thinking that if they became proficient, they'd potentially reduce length of stay for patients, and they wouldn't have to be in the hospital for as long because they wouldn't have to wait around for an echo.
An echo being a hand-carried ultrasound study that takes a look at the heart and the function of the heart.
You'd empower a physician to actually make clinical decisions that they'd otherwise have to wait a couple of days sometimes to get their echocardiogram. If you look at the control arm of that group, they were getting regular old good care at county, and then we were trying to do something innovative by seeing how granting this new facility to physicians would actually impact and potentially improve care. I think you can achieve that goal of learning important stuff about how to care for patients, future patients, while actually caring for the patients who you're currently caring for.
I felt like sometimes there was an unnecessary split between quality improvement and research. Good quality improvement is informed by good research design. It felt like your focus on this particular study, and I know for other studies, was this is quality improvement work, and can we do it in a way that answers the research question?
Yeah, there's this whole world of implementation science. A lot of the projects that we were doing were less about implementation because they hadn't yet been demonstrated, and they were more about real research. Like, does it make a difference if you train up physicians on how to do point-of-care ultrasound, or does it make a difference if you have attending physicians work 4 weeks or 2 weeks, and how does that impact their own quality of life, and does it have any importance for patient outcomes?
Since that study, Brian, I've seen you publish quite a bit on point-of-care ultrasound and writing position statements for the Society of Hospital Medicine. Where do you see the future for point-of-care ultrasound, or where do you think there is untapped potential for its implementation?
We found in that study that you could readily train hospitalist physicians to use point-of-care ultrasound, and that their performance when measured against a standard echo was really good. And it wasn't that hard to do. You could spend something like 20 hours and you could train a hospitalist to do some pretty simple things that would be helpful when they're taking care of patients. But there's two things. One is it takes some time. You have to put down the keyboard and you have to pick up the ultrasound. That is a big hurdle for some docs at some places. I'm not sure what the solution is for that, but one thing that I have talked to with other point-of-care ultrasound leaders is this idea that, there's a lot of talk about burnout these days. There is something incredibly rewarding about being able to ask a question about a patient's current state and then use something like point-of-care ultrasound to find the answer to that. So I think that point-of-care ultrasound has real potential, not only improving patient care, but also in improving the enjoyment of the practice of medicine. A lot like, you see some physicians who love to do the physical exam. I think the physical exam's great. We have some people at county who were like that. And I think this class of doctors who's particularly good at point-of-care ultrasound has that kind of reward from doing it that many of the old school docs that when I was in medical school that were training me had an enthusiasm about the physical exam. if you want to call it therapeutic POCUS or procedure-based POCUS, we're using the ultrasound basically to figure out if you're sticking needles in the right place. That should be universal. I mean, you probably remember the experience of trying to put in a central line just by feeling the pulse, and theoretically the vein should be just to the right of that, and you put in that central line and you're not sure whether or not...
Anxiety provoking.
Oh my gosh. And then to do it with an ultrasound is a completely different animal. My hope is that people's entree into point-of-care ultrasound is for therapeutic purposes, but then once they get accustomed to it, they keep it for the diagnostic as well.
Speaking of animals, maybe a rough transition, but you know, I was always struck by your persistence and can-do attitude. One specific thing I remember is you hoisting a table up 7 flights of stairs with a pulley system because it wouldn't fit in the elevator. And you had to do it on the weekends because you couldn't let anybody see you do this. But you ended up with a beautiful conference room table. Where the animals come in is, I understand since you left Chicago and Cook County and decided to live in a more rural area, that you took up farming.
Yeah, there's... It's too generous to say I took up farming. We have about 20 or so laying hens, and currently we have 7 pigs. We've been doing pigs now for about 5 years, and yeah, it's loads of fun. It really is, and it's not that much work.
I've got to stop you there because I remember hearing Sandy Lerner, who was one of the co-founders of Cisco. She went to a career in farming, and she said farming is so much harder than starting a tech company.
Well, that's
I hope
the thing.
I quote her right, but yeah.
I mean, being a real farmer would be really challenging. I have a nephew-in-law who's a real dairy farmer. That seems like a hard job. But we just have, you know, honestly, if you've got enough land and you eat pork, you know, a lot of people don't, but if you've got enough land and you eat pork, it's a great way to make use of your table scraps. I heard this one statistic, I'm not sure if it's accurate, but something like 90% of household garbage by weight is food waste.
Even when you have 4 kids.
Yeah, four kids. We just have a big old slop bucket that's like a 5-gallon bucket, and we just, you know, pour all the scraps and everything in there. And just take it out to the pigs, and they love it, and it's fun to watch them eat it.
And how does Lucas pork taste?
It's incredibly good. I don't know. I'm not even a pork connoisseur, but I've been told it's very good, and maybe we need to scale up the operation a little bit.
I was curious about combining your, you know, maybe this is an Occam's razor moment, but POCUS and farming. Do you ever use ultrasound on your pigs?
No. None of my doctor/veterinary skills have had to be put to the test with these pigs because they're just easy, honestly. We're not saving any money because at the end of the day I do all the calculations and it winds up being something like $5 to $7 per pound. Now that's still less than you'd spend on really high-end, organically raised, kindly raised pork that you'd get at a farmer's market or something like that. I know people have different opinions about eating meat, and I totally get that. But the strange thing to me is when people are horrified that we slaughter our pigs, but then they're eating the typical type of pork that you'd buy at the grocery store. That's always been confusing to me because these pigs, we have this almost 2-acre paddock for them, and they live a happy life, at least for a while. Yeah.
So what's next for Brian Lucas?
So I'm here at the VA. It's also mission-oriented healthcare, which I feel good about. I currently spend a lot of time doing research using the VA database to try and determine how the pandemic impacted veterans, particularly veterans who didn't have COVID. Like some of the work that I was doing at County, the beauty of County was being able to access that large database that you and Weinstein set up, and then being able to ask questions of the database.
Must be rewarding to be able to do that on a much larger scale with the VA database systems. What advice would you give to somebody who's considering working in a government safety net institution such as Cook County?
I wound up hiring a lot of folks at Cook County. I had this little line that I would tell them that was, because I would have to sort of apologize for our starting salary, especially if these were people that had come from prominent institutions and they had other options that they were being offered. I would try and get them to think critically about what it is worth in dollars and cents, what it's worth to them to actually care for the types of patients that you'd care for at a mission-oriented place. Patients that are otherwise often underserved, who are incredibly grateful oftentimes for the care that they receive without a hint of entitlement. We'd have this discussion, and what is that worth to you? Is that $10,000 a year in salary? Is that $20,000 a year? I think that is often not baked into the calculus about where people want to work. I was often competing against bigger name institutions that had some academic credentials behind them. I was always trying to make the argument, well, okay, so you won't be able to brag to your parents about the fact that you work at this fancy place, but your day-to-day and what you're actually doing and how you're feeling about the accomplishments that you've made and who you've cared for that day, that's worth something. It's at least worth what they're not paying you at those other places.
This is the place that I should probably caution the listeners who are parents and deciding that their child should spend $60,000 to $70,000 a year for college tuition. I say that in just because I really enjoyed working there, as did you.
Yeah. If I could just add one thing, that there's this interaction between physicians and patients. It's almost a negotiation about what kind of care you're offering, what kind of care they're receiving. I always thought that the beauty of a place like county or the VA is, and this wouldn't be a very good slogan for a healthcare center, but it's the place where you get the care you need, not the care you want. And let me just say, right, that's not the greatest slogan in the world, but I think there's an understanding at a mission-oriented place like county that because there are some limited resources, there's not going to be a surplus of care given. You're not going to get over-treatment.
And overdiagnosis.
Right. Being a physician in a place where you're never trying to peddle a particular procedure or a particular high-end medicine or whatever, but instead you're trying to sort of broker the best path for your individual patient, it's really a completely different perspective. I really don't want to disparage people that work outside of it. I just want to acknowledge that there is a conflict of interest that sometimes emerges at other places that I don't think you get at places like county.
Right. So one last question for you, Brian.
Yeah.
If you could choose one item to put into your physician's bag, literal or figurative, what would it be?
I have a couple of cheeky responses. One would be just a tie, which I'm wearing because I think it gives me a couple of IQ points.
Yeah.
I spend a lot of time now teaching epidemiology and biostatistics at the Dartmouth Institute, and I'm in the middle of this course that I teach in the fall. I'm a big proponent of this concept of taking information, prior information, and then trying to figure out the power of the thing you're doing, be it a diagnostic test or whatever, and then coming up with a posterior probability. And that's encapsulated in this Bayes theorem, right? Mm-hmm. And so theoretically I'd bring the Bayes theorem, put it in the doctor's bag, meaning that if you look at the Bayes theorem, there's two components of it: your prior beliefs and then the strength of the test. Most tests in medicine, they're not that strong. People don't like to hear that, but it's true. It's incredibly important in that formula is not the strength of the test. Most important is your so-called prior probability. That comes from being a really good doctor. That comes from generating a really solid understanding of how to interpret symptoms, physical exam findings, just having the experience of seeing a lot of patients who are coming in with a similar sort of problem. Knowing that it's not just about ordering a bunch of tests and seeing what the results are, but it's about being a good clinician at the bedside. That is an important thing that I'd always want to keep in my doctor's bag.
And that brings us back to your initial time at Cook County when you watched Brendan Riley go in, developing that prior probability before he ordered any tests.
Right. And even before he looked at the electronic medical record. To some that might be heretical. I teach on the wards and people have to talk about chart biopsies. Before they even go to see a patient, they want to spend a half an hour looking at the electronic medical record about that individual patient. And I try and discourage that because I think it clouds the picture a little bit.
Yeah. But this has been fantastic, Brian.
I'm glad to help, Bill. I think this is a cool idea.
After my interview with Brian, I spoke with Dr. Stefan Tchernodrinski, now the director of the bedside ultrasound program at the University of Illinois in Chicago. Stefan is working to export bedside ultrasound internationally to hospitals in Ireland and Bulgaria, and Stefan had this to say about Brian. Tell me about your experience working at Cook County, and in particular with Brian Lucas.
I still closely and strongly associated the two. His guidance helped me develop not only my clinical skills and my understanding of evidence-based medicine, but in particular the point-of-care ultrasound activities that are really defining my late career, if I may say so.
You mentioned your time at Cook County being a golden age of medicine. What about Cook County was special for your training and your early career in the United States?
The spirit of Cook County is something so memorable. What I remember and what I miss is the environment where everyone, every clinician, was determined to do their best in terms of clinical excellence, in terms of patient care, and in terms of acquiring additional knowledge and then sharing it with their peers. That was led by those titan clinicians like Brendan Riley, who was chair of medicine, by Brian himself, who was a superb clinician. And there's so many, I'm gonna probably miss a bunch. It was really a stimulating environment to develop yourself as a clinician, to be prepared to best take care of patients, and especially the vulnerable groups coming to Cook County.
Inspired to Heal podcasts are for informational purposes only and should not be considered as health or professional advice. We are not responsible for any losses, damages, or liabilities that may arise from the use of this podcast. The views expressed do not necessarily represent those of the host or the guest's current or past employers.